Dear listeners, welcome to Faces of Digital Health, a podcast about digital health and how healthcare systems adopt technologies. I'm your host, Tjasa Zajc. After a special series about digital health in Asia and Africa covered last year, the upcoming 4 episodes will present speakers from South America. A shout-out goes to Unity Stoakes and Jennifer Hankin from StartupHealth, who connected me to the speakers in the upcoming episodes. All the companies are StartupHealth Transformers. We are going to start with Argentina. I spoke with Adrian Turjanski, Chief Science Officer at Bitgenia, an Argentinian startup bringing genomics closer to society. In the upcoming episodes, you will hear from Luis Santiago, CEO of the Venezuelan healthcare IT company PEGASI.
A lot of people say, we want to expand to Latin America. It's usually thought about a single region, but each Latin America country is completely different. And then you have to know your lay of the land in order to grow in that market in a more effective manner.
I also spoke with Javier Cardona, the CEO of the Colombian telemedicine company Stoakes.
Indeed, we have a great system. It's pretty well designed. It is very strong in terms of insurance. Everyone in Colombia has insurance by the government, by their employer, or by a private insurance. 99% of the people in Colombia have some sort of insurance. The problem, and it is the weakness, is when accessing the systems. When you need some service from a provider, that's not a good balance between insurance and providers.
And Paulo Fernando Barque de Gusamo, CEO of Brazilian company Ottawa Health.
Brazil is the only nation with more than 100 million people with a public health system, a universal health system. And from the creation of this system in 1988, we have some very good numbers to talk about. For instance, life expectancy jumped 10 years since the public system was implemented. The child mortality decreased from more than 50 per 100,000 people to about 10. We have the biggest vaccination program in the world. We have more than 300 million doses per year to deal with more than 19 diseases. And this is all for free. We have the biggest organ transplant program in the world. More than 8,000 surgeries are done every year for free. But at the same time, so Brazil is famous all over the world about the AIDS program that implemented right from the beginning. So this public health system in Brazil has a very good things to be said about. But at the same time, it is struggling with lack of investments.
But first, Argentina. In this discussion, you will hear Adrian Turjanski explain the current state of genomics research in South America. He talked about the difference between the whole genome and exome sequencing and the use of AI in genetic sequencing. Enjoy the show and do subscribe to the podcast to be notified about other episodes in the series automatically. Find out more shows on our website www.facesofdigitalhealth.com. I also added the links to the series about Africa and Asia in the show notes. Now to Adrian. Adrian, the listeners of the show and the speakers are usually and most often from US and Europe. So let's start with the description of Argentina. How do you see it? How would you describe it in contrast to US or Europe?
Argentina is in developing country. So usually it's a very big and developing country. Our economy is small in comparison to many of the countries in Europe and the US. Argentina is very well known for agriculture products and everything related to farm. It's one of the largest countries in the world. So Argentina is very, very large, and it has all the climates. And in terms of the population, most of the Argentinian population comes from Europe. So we are usually like 40% Italian, 30% Spanish, and then from many different countries. So in terms of comparison also to our local neighbors, we don't have most people, original people from South America. So we don't have many people that are from Indians or people from the previous civilizations. So that makes a difference in Argentina. Then Argentina is a centralized country. Most of the things happens in Buenos Aires. That is a huge city with around 3 million people, but the surroundings go up to 18 million people. And the whole population of Argentina is 40 million people.
And you have a lot of scientists, right?
Yeah, so Argentina started with their national council that is very similar to Consiglio Nazionale della Ricerca in Italy or the CNRS in France. That we have a central National Science Council, and we have more than 20,000 scientists right now. And Argentina is very well known for scientists because we have 2 Nobel Prizes, which is a lot regarding our culture. And again, it's very well established because we have different institutions and very big universities. So the governments now rely a lot on local science. So Argentinians are also very well known for their development in technology. So it's not a very big industrial country, so it doesn't have very big industries, but in terms of IT and science is very good, and I think is one of the leaders in the whole region. The biggest companies in IT in South America are from Argentina.
And in terms of healthcare, you have the health system is decentralized, so public health is administered at municipal levels. You already mentioned that the country is very centralized around the capital, but in terms of the design, there's the fact that primary care is often independently managed by each city. Does that impact the quality of care available depending on where you live?
So in Argentina, we have 2 kinds of health, like the private one and the public one. The private one is all around the country, so and it's people who usually pays, but everybody gets the public health for free. So it doesn't matter if it's in a province in the north or in the south. What it will cover, it will be written in what we have is general, it's called PMO, that is the public medical plan, and whatever is covered in there it has to be accepted in the whole country. So, for example, there is a nice thing that is that a girl who has one of these rare diseases, one of the well-known ones, she was claiming that she needs the medication, and the president was saying, "I'm sure she needs this medication." So this reached our parliament. So in the Senate, they have to vote for this. And the president called and say, "I would really appreciate that you include this in the public plan because we should cover these people. They cannot afford it." And everybody voted for that because it was not included previously. So that means that in the whole country, then these people will go and they have to get the medication. And also we have like Medicare, we have a plan for people who are retired. And that's again, even though this plan will discuss which each province, for example, in which hospital do I go if I am retired, and if I am retired, I get the plan from the government. If I don't pay a private one, and if I get this one from the government, I will be directed to different hospitals because the government makes an agreement with different hospitals in different locations, but I will be covered by the same plan independently where I live. So it's a mixture, you understand, no? The hospital will be in a province, it will be paid by the government of that province, but my plan will be paid by the federal government.
Okay, so let's talk about the development of healthcare and specifically interesting solutions such as genomics and Bitgenia, which you are the chief science officer for. So Bitgenia aims at bringing genomics closer to society. So I wonder, what is the current state of genomic companies in South America? How developed is the market?
The market here, as I was saying, depends on the two private and public section. So as I was saying, some of the diagnoses are covered in the national plan and some are not. So that's also contributes to the development of the genomics environment. But instead of talking about companies, there is no much competition locally. So we are the biggest local company in the region. But we have competition from startups and companies coming from abroad.
Mm-hmm.
In particular, most of the companies that are coming here are from Europe. So genomics, we can divide it into clinical genomics and direct-to-customer genomics, and both involve health. In the direct-to-customer genomics, we have no competition. We only have some competition from some US companies that are sometimes sending their direct-to-customer solution. For example, 23andMe is not in the region, Ancestry is not in the region, but there are some of them that are coming with some representation to the region. But then there is no local solution for that, only the ones that we offer, Bitgenia. But in terms of genomics, there are no companies coming from the US. So big companies coming from the US are not here. We have all the services, analysis services. Most companies are coming, like Sophia Genetics or Centogene are the companies that are coming, and they are from Europe. And then we have some companies coming from Spain, like Diagnósticos Genómicos, because they have this, Spain has a connection with Latin America, not only because of language, because of culture, and also because they have a lot of companies here. So they usually expand their business to Latin America. So that is the competition that we have in the local environment. But as I was saying, in the whole world, we estimate that around 3% of the population has been sequenced or has undergone a genomic test. And in Latin America, our calculation made that only 0.1% of the population. So there is a huge market in that sense.
So you're only on the beginning of the development region-wise?
Yeah, you can see if you looked at the different countries, that depends also how the community accepts, so the medical community, and as I was saying, the public and private insurance accept to pay for genomic tests. In terms of direct to customer, we are completely in our infancy because it's just starting. And in terms of the diagnosis part, we are moving like 5 to 10 years behind. So it's still not here. So if you analyze the whole situation, like Brazil, Colombia, and Mexico are more advanced. Then Argentina, Chile, Peru, Ecuador are coming next. So there's still a lot of ground to grow.
So why did this delay happen? Why are you so behind? Is it culturally related? Are people skeptical or worried about privacy?
Usually we go behind, no? That's usually what happens with technology and many things. But in terms, for example, of smartphones, we are not that behind. But in terms of genomics, it's in terms of culture, because the thing is to really, this started like people sending the samples abroad and being analyzed abroad. That's what started at the beginning. So, and that it was mainly Europe and the US. For example, many people were sending to the Baylor College or Mayo Clinic or to Barcelona Center for Genomics. So special centers that people know, and the doctors were sending the samples there. And it was really very expensive. So very few people are able to pay. So I think that the main barrier was that the physicians didn't know how to work with that information. So if you talk, for example, sequencing is based on Illumina mostly because it's now the number one company. Mm-hmm. And you look at how many sequences they have installed in laboratories or public hospitals, it were really very few. So it was taking a long time because the government didn't make an investment. So it was just based on the private sector, and the private sector takes longer time. That's why we are behind, because neither the physicians know and the sequences were not there. Now the sequences are arriving. There are many centers that have the the sequence is there. And as we are here and Sophia Genetic is coming, other companies are coming, people are now learning how genomics. For example, is we just during the pandemic, we offer courses for the whole Latin America. And each time we offer a webinar to just explain how genomics work, you have 100 people or 150, and they are all physicians coming from different countries in Latin America that they didn't know about this and they want to learn. And in that sense, in terms of knowledge about genomics analysis, Argentina is the leader in genomics analysis. If we take out Brazil, no, because it was not even developed in Colombia, Chile, Peru, Ecuador. In Central America is much worse. In Panama, Costa Rica. So that's why, because I was also director of the Latin American Center for Genomics. And each time we were teaching, I was talking with the people who were in charge of introducing genomics in their country. So it will take probably now, because of COVID, another 2 to 3 years to reach the level that Europe has and the US has.
Since you mentioned the issue of development and awareness about the usability of genomics and genomic sequencing, what does this mean for pharmacogenomics, which is something that you're also offering? So deciding how the drug is going to be prescribed based on the genetic profile.
Yeah, so that we are already working with several labs. So most of the drugs are being also developed by big pharma companies. So we don't have local companies developing drugs in Latin America. So we are now being hired, for example, by AstraZeneca or by Novartis. And now they are starting telling all the physicians that they need to sequence, and they need to sequence to really do prescription and that they are drugs. So at the beginning, most of the pharma companies like Roche also were paying. So they were saying the physician, I will pay for the analysis. And in the last 2 years, they are just saying, we don't want to pay anymore. It's like the health insurance has to cover all this. And that's where we are right now. We are working with big pharma to do the analysis and show the health insurance companies in Latin America that they have to cover this, then to do the diagnosis and also to give the right medication. In oncology is more accepted than in other diseases.
Just before we continue with what the Bitgenia is doing and how are you successful with going to other markets in South America as well, let's explain some basics. So what's the difference between the full exome testing or the whole genome sequencing? I think this is going to be useful just for a basic understanding of the future discussion.
When you sequence the whole genome, you get usually the 3 billion letters of the genome, and you read all of them with the same quality. When you do exome sequencing, you only read the part that is the genes, that belongs to the genes, and you have different cover quality in different regions. So obviously the difference is in the terms of amount of analysis that you have to do. If you compare 2 genomes, usually you have between 2 to 5 million variants. And if you compare 2 exomes, you have around 30,000 to 50,000 variants. What do you use depending on what you are going to analyze? Now the standard for rare disease that is the most demanding challenge in genomics. It would be to do an exome. But in some cases, to do a genome will help, because some mutations will happen in regulatory sections of the genome.
So the whole genome is offered to whom? When do you do the whole genome?
So we offer the whole genome we have it as an offer. They have to pay a little more for that, obviously. And we offer usually for rare diseases, or when people want to do a whole analysis, because we can do what is used to be TGH, copying number. So we can do everything with the genome. So we offer to them. So some physicians or some laboratories will say, okay, to solve this case, I will do the genome. But if you are going to analyze, for cystic fibrosis, you already really know what you are looking at, and you know that you have 90% chance of finding something in the gene, you go for the exosome.
And to which extent does the usefulness of testing depend on the already existing data about the local population? If we mentioned before that only 0.1% of the population has been sequenced in South America, that means that the available data to do research and figure out which parts of findings are useful is much smaller than in the rest of the world.
Once you already know the biology of the disease, that you don't care because you just want to find the mutation, and usually that's easy. If you want to find a rare disease, you don't need to know the whole background. But once you want to analyze genetic risk, to know the background is very, very important. So we have now more than 5,000 analyses already done in the region. And we have also ancestry analysis of some populations. So what we usually do is to analyze what is called the genomics deriva, the variants where the study was done. For example, if a diabetes study was done in a European population, we will look at that one because we have a high population comes from Europe. So we will use those analyses. We will compare and we will look if we really have the same kind of distribution. Obviously, it's not the best. The best is to really have the whole population analyzed, but that's what we are doing right now. And one of the reasons that we think that Bitgenia is very important is because we want to analyze this population that will also help to analyze other populations. Because if you really want to know how changes in the genome are doing changes in disease, you need to know the genomics of the whole world. So it's a pity that Latin American data is not there in the genomic databases.
One of your goals is to sequence 1 million people in South America in the next 5 years. So what are the biggest problems or barriers to success in this regard?
We have, I would say, 3 different barriers. One barrier is, as I was saying at the beginning, that is growing each year. The barrier is lowering. That is that the governments and the health insurance company cover the genomic test. So this is moving very fast. If you move in different countries, you can see how once the government accepts to pay something, it grows exponentially. So that's one issue. The other issue is that we need to really advertise and sell in each Latin American country our direct-to-customer solution. So that's why we expect to do this in terms of we receive the investment to do it. And we set up that number because we are seeing how it grew in other countries, in other developed countries, when the genomics started to be accepted. And that's the numbers that we see. It doesn't matter if it's exactly 1 million. No, it's a goal to show that if we receive the investment to really advertise everywhere, we will be able to do that, because some countries are running ahead and some countries are coming behind. But it's a small portion of the whole population. We have 600 million people in the whole region. So we don't think that it's very difficult to reach that. But we have to not only to accompany what's going on with the public health insurance and private health insurance, but also to advertise and to show that genomics has to be recognized. So nowadays, most of the physicians and people have seen something about genomics. They have been to a congress and they know that now it's the state of the art. Or people have seen something that happened with 23andMe or some other companies, and they don't know that they have a solution to do this in Latin America. Mm-hmm. So each time we enter a small region, we start receiving people who really want to sequence their DNA. So that's why we believe it's something really feasible.
What was the project or projects that you found most exciting up until now with Bitgenia? One of the things that you were involved with was the 100 exomes project, which, if I'm not mistaken, was aimed at solving rare diseases and just how they're diagnosed. helping with that?
So that was our first challenge a few years ago, to show everybody in Latin America that, and especially in Argentina, that exome sequencing is the key to diagnose many of the rare disease disorders. So 3.2 million people in Argentina has a rare disease, and 80% of those diseases are of genetic origin. So we did that. After doing that, then we were able to sequence more than, right now is around 3,500. So we have 3,500 exome sequence of rare disease. So this really showed the people that we were able to do it. Now I would think that the most exciting thing I expect is that we start sequencing with our DTC product a huge amount of people, and that we are able to do research with that. So what we expect is to be able to manage the Latin American population. Just we started with this just a few months ago, and we already are correcting many of the outcomes that we give to people based on the local population. So I expect that we will be able to have very good data, and that we will be able to show the world that how analyzing the local population can impact many of the outcomes that people are doing in Europe or the US. That's our expectation, and that's what I think it will be fascinating in the next years.
I imagine that that project brought you quite a lot of attention, to spread the word about the company.
The goal is that to reach the moment in the years to come that everybody will see that sequence their DNA, that they can share with the physicians, and they can use our platform. If they go to the hospital, they see our platform. If they sequence their DNA for a diet or for activity, for everything that involves genomics, they can also use our platform. So if we are able to do that, it will be fascinating then to start doing correlations and show people many of their results, and show, look, this is what happens in Latin America. And we are now starting to something very easy to do right now, and is something that I just to show you is an idea. But in Latin America, in the south, from Paraguay, Brazil, Argentina, we drink mate. Mate is if you have chocolate, you have tea, you have coffee, and you have mate. Those are the beverages usually most standard. And many people now in England are drinking mate, or in Barcelona because Messi is there, or because Argentinian football players are there. And the Pope is drinking mate because he's Argentinian. So what we did is in collaboration with the university, we sequenced the mate genome, and we analyzed the metabolites. And now we are trying to show the local community, not only how your genetics change when you drink coffee and how you metabolize caffeine. We have caffeine in mate, but we have other kinds of metabolites that are very important, like chlorogenic acid, for example, that is very good for Alzheimer and many different diseases. And we will try to show how that beverage will impact their body, that everybody is talking, but they don't know about their genetics and how they react to the mate, for example. So that's something to really talk to our local community, to show them why genomics is different here, not only because you have a different background, but also because your habits are different.
Sounds like something that could attract a lot of media attention.
Yeah, so here we always attract media attention. I have been interviewed by newspapers, the most famous newspapers in Argentina. I have been interviewed here. I have been interviewed by radios. Each month I have a new radio that do the interviews, magazines, because people really see this as something really new, amazing, and they didn't know that a local company could really develop this. And the last thing to tell you about that is that now we are including, because we want to be local, we are including ancestry results. I did my 23andMe, and I only finding Russian relatives who live in the US, because I came from Russia, so all my family came from Russia. But now I found, by doing my own test, I found a cousin here. So we believe that people will start doing this, because if they do the things abroad, they compare to populations abroad, and they need to compare with local populations. But that will depend if we are able to grow as we expect.
One issue that can happen in genetic testing are incidental findings. Do you have any guidelines on the company level in regards to what to do about those? So if you're looking for something by sequencing the genome, and you might find something else, so that a person has another disease or a predisposition for another disease. So to which extent do you already, before the research, ask participants what do they really want to know?
So when we work with physicians or laboratories, we give the physician the option, and they will ask the patient. So they will ask the patient. What we think is that we have the option for them to ask or not to ask. So we offer them that they have to ask the patient, but the patient can say, yes, if you find something, and we clearly specify then which are the incidental findings we are going to analyze. We are not going to analyze all the incidental findings, the ones that are suggested by the American College of Medical Genetics. And they know that if they want, they can get that information. When we give a test directly to the public, we already tell them that there are some things that they will get directly, and they have to consent for that. And if they want to find some outcomes that we tell them that we are going to analyze, but they will have to double sign. So they have to be sure that they want to see, for example, for women, if they will get, for example, you are red hair. So we analyze if you have a genetic of red hair or not. That information, you have to sign only once, and you will know that if you have the genetic of red hair or not. Mm-hmm. But if you want to know if you have a breast cancer genetics, for example, mutation in BRCA1 or 2, then we let you know that information is in there. If you want to see it, you have to accept it. When you do the genetic test for people, we are all the time doing new analysis, and we are sending this to people. So when these findings could have an impact on people's health, people can decide not to see them.
As a scientist working in the genetic space, what are your expectations of the CRISPR technology?
So in the CRISPR technology, we have some also local companies developing CRISPR solutions. One is now developing a test for COVID using CRISPR, but CRISPR is very, very important once you identify a genetic disease. Mm-hmm. So we expect to be working, we already are having discussions with these companies that we could do both things. So they could offer their solution, but we could also diagnose first, then give them the information, and then they can work and see how that may have an impact. Nowadays, CRISPR is only accepted for very limited cases, but first you have to do the genomics. So that's how we can partner with them, because we can do the diagnosis and then they can work with CRISPR. But it will go hands to hands in the future once CRISPR is accepted.
Given that you are working with analyzing large amounts of data, how does using artificial intelligence look like with you? So how are you following that development, and what seems more promising for your specific case?
So we are using artificial intelligence at different levels. Now we are also having a partnership with an European company that focuses only on artificial intelligence. And the two parts that we use now artificial intelligence is first to classify the variant. When you analyze if it's pathogenic or not, or what is the outcome in the gene, we use artificial intelligence, but also we are now developing a tool that goes from the clinical history to the gene, because in many cases, it just receives some annotation that comes from the physician. So we have an artificial intelligence tool that based on the phenotype, it will go directly and highlight specific genes. And then you go at the variants, and it allows you to do faster diagnosis or to identify new genes associated with the disease. So that's where we think that in the short term are going to be the biggest outcomes. In the long term, I believe that it's going to be the analysis between the genetic variants that we already will have in our database with all the other information that we will ask, and we are already asking the people, like if they smoke or not, what are their habits. So that's where that's the second wave that we hope it will come once we have a huge amount of genomics data.
By the way, how is the whole situation with COVID influencing you as a company? Because you have to work remotely because of the costs and the funding. Is your development hindered, or are you getting more interest from investors?
We are getting more interest from investors because we are already a company that do the test at home. The people can ask directly for the tubes. It can be saliva or it can be blood if we put paper. So it's fairly easy for us to continue working. The investors have seen this and now they are saying, well, we have to move from traditional conditions, people going to hospitals. So we have to think in a way that people are not going to go to the places to get their analysis. They will try to stay more time at home. Obviously, at the beginning, with the quarantine, everything stopped. But now we are getting more and more cases than before, because now everybody wants to use this kind of situation. And our platform is remote analysis, is web-based, so everybody can use it everywhere. That's what allows us also to offer our services in the whole region.
So just one last question. What are the most exciting things that you have on your roadmap, according to, your opinion?
The most exciting thing would be to, as I was saying before, to grow in the region and to really grow exponentially. So to be able to deliver the tests and analysis everywhere in the region. I think that will be really exciting because we will see data coming, and once the data arrives, then we already have the people to do the analysis and to do great new research and to really help our community. Because I found really exciting that locally people used to send things and only rich people were able to send their results to clinics in the US or Europe, and now they realize they can do these tests locally and they can really analyze and get outcomes, and that this can change their local habits and what they do, and people really trying to help them. I think it's exciting for us because we see a change in our communities. Like, people are really grateful that we are doing this.
You've been listening to Faces of Digital Health. If you enjoyed the show, do leave a rating or a review wherever you get your podcast. Every opinion counts. Thank you.